Tomorrow. Okay, got it. So Arlo Simpiria Suin, Jamaro, the Manet teaching or Professor Griffiths Gani Biroma English Lue conduct lupame, Jama moderation ale, English Lue conduct lupame. The Gelu Meziari Bari Shire Yamalu Majine Suin Guagu a mute Lopirom Yamalu Le Milu Yarishin. So allow me to introduce Professor Chris Griffiths with great pleasure and privilege. Professor Griffiths is Foundation Professor of Dermatology at the University of Manchester, and he is well known all over the world as the editor-in-chief of one of the leading dermatology textbooks, the Rook's textbook of dermatology that we all the dermatologists in the UK have to learn from. But of course, in addition to this, he's one of the most influential and widely published dermatologists worldwide because of his expertise in psoriasis, skin aging, and others. So I've had the privilege to co-found a charity called the Burma Skincare Initiative charity with him in 2018. So I invite you, Professor Griffiths, to give the Common and Emergency Skin Disease in Adult lecture to the final part to Myanmar medical students. And I do hope that there will be some GPs as well online. Okay, the floor is yours, Professor Griffiths.
Thank you very much, Dr. Lewin, for that very nice introduction. And thank you to the Myanmar team for inviting us to speak to you on skin diseases, which is obviously a very important part of your curriculum. What I'm going to do over the next hour, I think we have this morning, is to talk to you about common and emergency skin disease in adults. There'll be a talk I think next week on skin disease in children. But I'm going to begin by telling you a little bit about where I work, why I'm interested in helping you in Myanmar, and then go on to the more specifics of how to examine a patient with skin disease, how to take the history, how to describe a lesion and a rash, which is so important. And then go through a few, we can only go through a few, common skin conditions in adults and a few emergency skin conditions in adults. And this is just going to be a taster of skin disease in general. So I work in Manchester, which is it's a famous city, mainly because it was the first city of the industrial age. It has the largest university in the UK and the largest medical campus in Europe. It also has some other important institutions, such as our football clubs. I work here in Salford, which is part of Manchester, which has one of the largest dermatology centres in England, in the UK. The other large one is actually where Dr. Lewin works, down at St John's Institute of Dermatology at Guy's and St Thomas's Hospitals in London. But and I have been in Manchester for more than 25 years now and still chair the department there. One of the reasons I'm speaking today is because, as I'll show you, Dr. Lewin and I have founded a charity, the Burma Skincare Initiative, about 2 to 3 years ago. And my first visit to Myanmar, at the very kind invitation of Dr. Lewin, was at the end of 2018, where I visited dermatology departments in Mandalay, here with Professor Lewin, and also in Yangon General Hospital with Professor Kang Kain-Saw, where we were very graciously received and saw a lot of patients and a lot of important discussions about skincare in the country. I revisited just about 2 years ago now, where Dr. Lewin and I visited some orphanages and did impromptu skin clinics there, where we saw a lot of skin disease, particularly infection. And also we did a clinic in the very far south of Myanmar, in Kathong, at a general hospital there, where we saw a number of very interesting cases working together in a clinic over the course of one day. But we felt that we could work with our colleagues in Myanmar to develop skincare excellence based around clinical services, research, and education, and a sort of sustainable initiative between the UK and Myanmar. And as a consequence, we founded the charity, which got its registration 2 years ago, but the charity was founded before that in the Burma Skincare Initiative. And on the right here at the Shwedagon Pagoda, myself, Dr. Lewin, and our other trustee, Mr. Stephen Liu, who's a barrister in London. So let's begin at the very beginning and talk about, skin anatomy. So what does the skin do? Well, the skin is an important physiological barrier. It's important in maintaining fluid balance, and it provides an innate immune defense against fungi, bacteria, and viruses. And that's because the skin produces antibacterials, bacterial such as the defensins, and also contains Langerhans cells, which are the outermost point of the immune system, where it provides immune surveillance. It also produces, it's also important in thermoregulation and insulation and protection against trauma. And both the fat and the epidermis, the upper layer of the skin, are very potent immunological and endocrine organs in their own right. So when we talk about skin, it's not just the skin, it's also the hair and the nails are what dermatologists are interested in. We have the epidermis, which has these keratinocytes, and as the main cell, it also contains Langerhans cells. And then in the dermis, there are fibroblasts and the main vasculature and sweat glands and the pilosebaceous glands. And deep to that is the fat. And we're interested in diseases of all of those structures. So when you see a patient with skin disease, it's going to be very similar to as you would approach any other patient you would see in your clinic. The first question is there anything wrong with your skin, hair, or nails? Important question is probably the main symptom in dermatology is itching. You ask about itching. Important to know how long they've had the skin trouble. Does anyone in the household have a similar problem? Are they taking any medicines? And how is the general health? And that's because question 3 is about infection. Question 4, or question 3 could also be about genetics or inherited conditions. Question 4 is important because of the importance of drug reactions. And for question 5, general health, is that the skin is often the sign or the underlying systemic disease, such as maybe systemic lupus erythematosus, SLE. So taking the history, one needs to think about, does the patient have a rash, or do they just have a lesion, a single lesion, say such as a skin cancer? So again, it's going through the presenting complaint and history of the complaint, the past medical history, the drug history, family history, social history, and systemic inquiry, as I've just described. And I'm going to go through those as far as a rash is concerned and a lesion is concerned. So this is the general history as far as medical history as far as a rash is concerned. So you're interested in associated symptoms such as pain or itching or discharge, or have there been any blisters? Past medical history is important, particularly if there's a previous history of skin disease, such as particularly in the case of eczema or psoriasis. Think about underlying conditions such as diabetes and inflammatory bowel disease, because they may be relevant because there are a number of skin problems associated with diabetes, inflammatory bowel diseases associated with skin problems such as psoriasis or pyoderma gangrenosum. Drug history, as I've mentioned, is important, and it's not just medical, it's not just medicines, it's also other non-medicinal treatments that the patient may have taken, which might have produced some form of reaction or allergic response. Family history, particularly with psoriasis and eczema, social history, occupation, particularly if one's thinking about a contact dermatitis, is the rash improves when the person isn't working? Who else is at home? Do they have a skin problem? That's particularly important in conditions such as scabies. And then, as I've mentioned, systemic inquiry, does the patient have joint pains or fever, which might lead you to thinking they have a connective tissue disease. With a lesion, it's a little bit different and not such a detailed history. Again, you want to know whether it's been an intermittent or continuous lesion. Past history, particularly in the relevance for skin cancers, because if someone's got a skin cancer, they may have had them before. Drug history is important, particularly if you're going to do surgery to remove the lesion. So are they on any blood thinning treatment, or do they have a pacemaker in situ? Family history is important, particularly with skin cancers. There are skin cancers that run in families. Occupation, and particularly in outdoor workers, and then a systemic inquiry. It might be worth asking about weight loss, because some cancers are associated with that. Now, you're going to get a copy of these slides or have access to these slides afterwards, so don't have to take lots of notes. But as you know, it's very important to be able to describe what you're looking at, because I think description is just like if you're describing a painting. If you can describe it accurately, then you can actually talk to someone about the lesion you're looking at, but also it allows you to identify what sort of condition you are dealing with. So just a couple of the important ones for our talk today. So a bulla is a blister, and one that's more than 1 centimeter in diameter. A vesicle is a very small blister that's less than 1 centimeter in diameter. A macule is a lesion which is less than 1 centimeter in diameter, but you can't feel it, whilst a patch is much larger and is greater than 1 centimeter. But if you run your fingers over it, you can't feel that. Nodules and papules are just a difference in size, but they're elevated, well circumscribed lesions. And then plaques are, again, like a patch, but are raised, particularly as in the case of, say, psoriasis. These other definitions are more associated with particular conditions, such as whealing is associated with urticaria, and then excoriation is a sign of scratching, and the ulcer is if you've got full thickness loss of epidermis, such as in a venous leg ulcer. So it's important when you're looking at the lesions to think of sort of 5 S's: the site, the size of the lesion, is it symmetrical in its shape? What's the shape of the lesion, and what's the surface look like or feel like? Those will help you guide you towards the diagnosis. So this is the first lesion. This is well circumscribed. This is looks though it's fluid filled. This is a bulla because it's more than 1 centimeter across. This is small lesion. It's pigmented. It's well circumscribed. You can see here that probably you wouldn't be able to feel this. And this is a macule. This is a raised lesion. So if you ran your finger over this is in fact a form of nevus. You'd be able to feel it, and that is a papule. Then here is a much larger lesion. This is what's called a Keratoaganthoma. It's similar to a squamous cell cancer. You can see this is nodular. It's mainly coming from the dermis or from the and the epidermis as well, because it's crusted. And this is a nodule because it's larger than 1 centimeter. This is a discoloration of the skin, probably vitiligo. If you ran your finger over that, you wouldn't be able to feel it. This is a patch. And then this is a raised patch. So if you ran your finger over this, you'll be able to feel it. You can see it's well circumscribed. And this is a plaque, as we'll see when we look at some pictures of psoriasis. So these are important terminologies to know, because then you can describe the lesion and understand it better. And this finally is a pustule, which is a pus-filled vesicles, like a small blister, less than a centimeter in diameter, and that's a pustule. And this is crusting, which you see over a variety of different conditions. It's usually due to exudate. This is in the case of psoriasis, actually, there's some scaling and crusting. You see this yellowish exudate, which is crust. With rashes, it's probably important to ascertain whether they are asymmetrical. Are they just on one side of the body, or are they symmetrical on both sides of the body? Other important aspects to take into account are they on exposed skin, extensor sites, flexural sites? Are they around follicles? Do they display the Koebner phenomenon, where they occur in sites of skin trauma? Particularly see that in lichen planus and psoriasis. But again, I'll give you a copy of these slides. You'll be able to see what these are referring to. So these are two examples of here's an asymmetrical rash. This is just on the back of one leg. And this is a condition called Lichen Striatus. It's similar to a condition called lichen planus, but this is just on one side in a dermal-tomal distribution. While here it's a symmetrical rash. This is psoriasis occurring in a mirror image on each elbow in each forearm. Usually symmetrical lesions tend to be endogenous. Asymmetrical are often exogenous causes. In this case, this is genetically inherited. Important to look at repetition of lesions and also the pattern. So take a step back, look at the patient, decide whether they've got a rash or a lesion. Is it symmetrical? Is it asymmetrical? Is it a pattern? There are a number of different terms used for the lesions themselves. So the shapes of lesions are, as you see here. I'm not going to go into any detail here, but everything from a digitate, which means finger-shaped. People talk about discoid or nummular lesions. It means they're like a circle or coin shape. This is such as you see in nummular eczema. If it's pedunculated, this means it's a papular nodule attached by a thin stalk, which you see in skin tags. And then polymorphic, and we'll talk about this, this is different variable sizes and shapes, as well as types of lesions. So there's lots of different lesions there. It's not homogeneous. You see this particularly in acne. And then how about polycyclic? This is coalescence of several rings. You might see this in forms of lupus erythematosus. And umbilicated lesion with a small surface depression, you see in molluscum. So again, the shape of the lesion, as well as the form of lesion, is important in the overall description. And quite often, if you can describe it accurately, you can come to the right diagnosis. So what does the dermatology need as far as bedside tests are concerned? Well, we don't need much equipment. People nowadays use this instrument here called a dermatoscope, which is polarized light. It's a lens. Put some oil on the skin with the lens, allows one to see the surface detail much more clearly. Skin swabs are important if you think the patient has an infection. Mycology, you either take skin scrapes, or in the case of Tinea Capitis, hair plucks. Don't scrape the skin if there's tinea, if you think the patient has Tinea Capitis. Or Wood's light is a source of UV light. It's a black light, and that will enhance the difference between non-pigmented and pigmented skin. Skin biopsy, if you think there's a need to have further information about the diagnosis. Then patch tests for contact dermatitis, and prick tests for type 1 allergic responses. No, I'm not going to talk much about therapeutics today. You're going to have a lecture about dressings, but there is a variety of different therapeutics that we use in dermatology, from topical therapies, which include ointments and creams and lotions, dressings, which is really bandaging, local injection, often with a steroid. Systemic therapies, we use a lot of systemic therapy, and be particularly at the forefront of using the new biologic therapies for diseases such as psoriasis. Phototherapy is ultraviolet light, either UVB or UVA, used in combination with the combination with a photosensitizer, something called PUVA. Then we can excise lesions as we do for skin cancer, or we can just physically destroy the lesion using liquid nitrogen cryotherapy or cautery or diathermy hyphacation, which are all forms of heat, and then laser treatment, which is used for a variety of different skin conditions. So there's quite a armamentarium of different therapeutics. So let's begin with let's go to some clinical cases now. So we've talked about how patients might present, the importance of the history, the importance of being able to decide whether it's just a rash or a lesion, or symmetrical or asymmetrical, and then to be able to describe the lesion itself. So this is on the chin. These are little vesicles here. These are crusted. There's a golden color, and this is impetigo. And this is a bullous form of impetigo. You can see this is these are blisters, but these golden crusts are very characteristic of impetigo. So bacterial infections are caused by either gram-positive bacteria, such as Staphylococcus aureus, or rarely group A streptococci, especially in tropical climates. These may develop on their own, primary infections, as I've just shown you as impetigo, or they may be a secondary infection, as we see with people who have scabies. They can often get secondary infection. They can affect anyone at any age, but they're more common in childhood, but not limited to childhood by any means. And there are several common forms of infection, as I'll show you: impetigo, cellulitis, and other bacterial skin infections such as folliculitis. So with impetigo, the honey-colored crusts are the key to the diagnosis there, as I've shown you. If the lesion's deeper, it has this strange term called eczema, where there's often a black crust. It can affect any part of the body, but they're commoner on the face in impetigo. It's particularly common in children. You should treat underlying skin conditions first, such as scabies or eczema. An antiseptic wash, such as chloroquine or chlorhexidine, is and a more effective and cheaper approach. And if it's more extensive, then a systemic antibiotic, such as flucloxacillin or erythromycin, may be indicated. So this is a different form of infection. This is painful. It's red. The patient is systemically unwell. It's limited here to the lower leg. You can see here that the people looking after this patient have marked the edge to see if it's expanding. And this is cellulitis. So cellulitis can take a number of forms. It's usually, as you can see here, usually on the leg. It can become eroded. The patient often has systemic symptoms such as rigors. And if it's on the face, it's often referred to as erysipelas, sudden onset, very painful, and the patient is often systemically unwell. So cellulitis can be serious if it's left untreated. As I mentioned, they're tender, hot, and swollen. The border of the lesion is not well defined, often usually caused by group A streptococci rather than Staph aureus, as I mentioned with the impetigo. They have systemic symptoms, and if patients have lymphedema and chronic limb swelling, they may be much more predisposed to cellulitis. And remember, a patient who has Tineapedis, it may develop from that site of entry. The treatment for cellulitis, oral antibiotics, not topical antibiotics. If the case is severe, then high dose of intravenous antibiotics are required, and some patients require chronic treatment to prevent relapse. And then you should always look for the underlying or predisposing cause, such as eczema or Tineapedis, which needs to be treated. Now, this is another case now. This is a patient with well-demarcated scaling lesions, as you can see here, really quite widespread on the upper back and the lower on the flanks, and also moving on to the abdomen as well. Scaling, but with a well-demarcated edge. And this is Tinea Corporis, fungal infection. You can see here some different examples of this. Again, they all have the characteristic raised edge, and even here you can see it here. This is also known as ringworm. It's a fungal infection that can affect any part of the body or limbs, though it's rarer on the face. You have similar infection in the groin, is called Tinea Crorus. As I've mentioned, the outer edge is the important thing to look for. That's often advancing, and there's sometimes pustules in those lesions. If this is available, you should take skin scrapings for microscopy, because this will confirm the presence of hyphae, and it can be cultured. And the commonest cause here is Trichophyta rubrum, often spread from Tineapedis. The treatment is topical antifungals, and there's a variety which are available. An old-fashioned one, but still very effective, is Whitfield's ointment. And widespread infections, you should think of using an oral antifungal, such as terbinafine, griseofulvin, itraconazole, or fluconazole. I think fluconazole is used more commonly, I think, in Myanmar. And the systemic treatment should be for 2 to 3 weeks. Tineapedis is the commonest of all fungal infections. Usually it's interdigital. You can see here the sort of scaling and itching between the toes. It's transmitted between humans, particularly on wet floors. It can cause general scaling on the sole, and is often the cause of more extensive Tinea corporis and Tinea Crorus. And there may be vesicles or small blisters between the toes or scales. So just always a worthwhile checking for this moccasin-like distribution. And then the alternative diagnosis to Tineapedis is a gram-negative bacterial infection and also Candida. Topical treatment is usually all that's required for Tineapedis. Occasionally may require systemic therapies. And it can be particularly recalcitrant if the patient has lymphedema. This is a very common presentation. I think you may have all seen this. This is the hand of a teenager. See these vesicles on the hand, on between the fingers, and this is scabies, very itchy. It's caused by a burrowing mite called Cercoptes scabii. It's transmitted by close human contact, produces intense itching, and often patients present with eczema as well. It's important to look for, as I'm going to show you, the little burrows, the faint curvy lines on the skin, particularly on the flexor aspects of the wrists and also in the finger webs. But important in adults, particularly to look on the external genitalia and the breasts. Several members of the family may be affected. In men, particularly, check for small nodules or spots on the penis or scrotum, and nursing mothers, itchy spots around the nipples, and also an itchy baby, of course. And if the patient is elderly or malnourished or immunosuppressed, such as with HIV or AIDS, then crusted scabies, which is very extensive scabies, which looks nothing like scabies, looks more like a eczema or psoriasis. That's important to diagnose that, because that can be a very significant problem. And these can become secondarily infected, and this is the commonest cause. Scabies is the commonest cause of chronic renal failure globally. So this is Cercoptes scabii, the culprit mite. These are the little burrows you can see here, which between the finger webs. Much more extensive here on the back, where you can see the scratch marks. This is this crusted scabies that I mentioned, long-standing, indolent, very extensive disease, particularly in the elderly, malnourished, immunosuppressed. And this is in an adult. Just the only sign here of scabies with these little nodules on the penis and scrotum. Treatments, it's important that the absolutely key is that a single application of permetamine is left on for up to 24 hours. In adults, you don't need to treat the head, though in children, often the head is affected. Malathion is leave on for 24 hours and then bathe. You should repeat these applications a week later. And all members of the family should be treated. And bedding and bed material should be washed at least at 50 degrees centigrade. And then if it is particularly recalcitrant, or in those cases of crusted scabies that I've shown you, then very effective oral treatment is ivermectin, given as a single oral dose. So let's change track now. This is a young man who presents with these patches of hair loss on the scalp. Not itchy, no sign of inflammation. This is alopecia areata. So alopecia areata, the classic, absolutely hallmark characteristic feature of this is that there's no inflammation, but hopefully you can see here these so-called little short thickened hairs called exclamation mark hairs, which you don't see with any other naturally occurring cause of hair loss. You can see these if someone's had a hair transplant. So this is an autoimmune inflammatory disease, non-scarring, usually occurs before the age of 40, equal sex incidence. It's associated with other autoimmune conditions such as atopic eczema, diabetes, thyroid disease. So there's a family history in about 20% of people. And you have these circumscribed, hairless, smooth patch with the exclamation mark hairs, as I've shown you. The progress is unpredictable. Some people can go to loss of all the scalp hair, which is called alopecia totalis, or in some unfortunate individuals, all body hair is lost, called universalis. Usually with this form of patchy hair loss, there's spontaneous regrowth. The eyebrows and the eyelashes can often be involved. Corticosteroids applied systemically, or the very potent ones applied topically, may be effective, as can topical sensitization with diphencyprine. It's a very difficult condition to treat, but I should have put this in the slide. There's now good evidence that the Janus kinase inhibitors, JAK kinase inhibitors, are an effective treatment for alopecia areata, which is very good news. Let's move to the next patient. So this is a young woman, probably in her 30s, who presents with this rash. She looks as though there's some blisters there with a lot of erosions. It's painful, and this is Pemphigus Vulgaris. Now, people may get confused about pemphigus and pemphigoid, so I'll just take some time out here to go back to that anatomy. Pemphigus is one you have antibodies to components of the epidermis. So these are components to the desmosomes that hold the brick wall of the epidermis together. So desmoglines and desmocollins. Whilst pemphigoid is another autoimmune condition, sounds very similar, where the antibodies are directed to the basement membrane proteins. So they separate the dermis from the epidermis. So you can imagine that with pemphigus, the split is going to be in the epidermis. So the roof of the blister is very fragile, which is why you often don't see any blisters. Whereas pemphigoid, the roof of the blister is the whole of the epidermis, and blisters are common. So let's go back to Pemphigus vulgaris. Important that it also involves the mucous membranes, as you see here. And then this is an immunofluorescence picture, which shows this green here, which is that when you stain with immunoglobulin, you can see this is deposited against these so-called desmogliin 1 and desmogliin 3, which are present within the epidermis. So it can occur at any age. It's not common, but it does seem to be particularly common in Myanmar. When Dr. Lewin and I visited Myanmar, we saw several cases on the wards. So it is a common condition, difficult to treat. It's associated with other autoimmune diseases, particularly thyroid disease and rheumatoid arthritis. Blisters are rare, as I've mentioned. And Nikolsky sign is if one runs one's finger over the uninvolved skin, it detaches easily. If you do that, I don't encourage you to do it. And that's because the skin is so fragile. The diagnosis is confirmed by direct immunofluorescence in the epidermis, as I've shown you here, and also circulating autoantibodies on what's called indirect immunofluorescence. It's life-threatening. The treatment has to be systemic, using high doses of prednisolone with or without, usually with azathioprine or mycophenolate as a steroid-sparing agent. And then some patients who don't respond to prednisolone may require a biologic targeted to B cells called rituximab. This is Pemphigoid. So this, you can see the blisters here much more clearly than you could see in the pemphigus. So these occur in an older age group, usually see tense blisters. The IG immunoglobulin are deposited along the dermal epidermal junction at the basement membrane because the antigens such as BP180 and BP230 are present within the basement membrane. They're particularly common in the flexures, and the Kolsky sign is negative here. There's no, or very rarely is there mucosal involvement, and the treatment can best be potent topical corticosteroid, maybe with doxycycline, but usually patients require prednisolone, but this time shorter courses with or without azathioprine or mycophenolate. So here's our next patient, another young person. This person is in their late teens, and they present here with, you can see here, pustules and papules. And if you can look carefully, you can see some little comedones here where my arrow is. So this is acne. This is one of the commonest skin conditions. I guess that pretty much everybody on this call today has had acne at some stage. It is polymorphic, and that the comedones, which are sometimes known as blackheads, which are blockage of the pilosebaceous follicle. It can become much more inflamed and painful and nodular and producing scarring, and it also can affect the upper trunk, as you see here. It probably occurs more commonly in men than women. The inflammation is linked to overgrowth of P. acnes bacteria. And there may be a systemic upset when there's a rare form of acne called acne fulminans. And it's important to treat these cases because they can produce scarring, which is much harder to treat. And certainly in darker skin types, post-inflammatory hyperpigmentation can occur, which may last for many months after the lesions have disappeared. Treatment is either topical using benzoyl peroxide, or if available, a retinoic acid cream or gel. Topical antibiotics are not so encouraged nowadays, nor are the oral antibiotics, because of the risk of antibiotic resistance, but we tend thromycin or doxycycline. Hormonal therapies, particularly oral contraceptive pills such as Dianet, is effective for acne in young women. And in the very severe cases, and to prevent scarring, oral retinoids such as isotretinoin, which are expensive and do have side effects that require regular monitoring, not least the high risk of birth defects, may be available in specialist centers. All these treatments require time to work. These don't work. It takes at least 6 to 8 weeks for any of these treatments to work. And it's important with acne to understand the psychosocial distress that it can produce. And depression and social isolation are really quite common with young people with acne. So let's move to our next case. This is a man in his 40s who has these very well circumscribed lesions that you see here. So these are well circumscribed, and very clear cutoff between the plaque. These are plaques. You imagine if you ran your finger over these, you'll be able to feel them. Very well circumscribed, a lot of scale, it's symmetrical, and this is psoriasis. So psoriasis is an immune-mediated inflammatory disease. May start in childhood, but usually starts in young adult life, usually in the early 20s, but the average age overall is around about 30. Equal sex incidence. It runs in families, so if one parent has it, there's a 28% risk that one of the child will have it, and if both parents, there's a 65% risk. The lesions that I've shown you are red on pale skin types, but in particularly in Myanmar, this is more going to be a gray color. I'm going to show you pictures of this. Classically, it's symmetrical. Affects particularly the extensor elbows, knees, also the scalp and trunk are involved. Scalp is often the first site to be affected, and people may think they have dandruff. And the nails and joints are involved as well. Nails in about 50% of people, and the joints, psoriatic arthritis, in about 30%. It exhibits this strange phenomenon called Koebner, where you develop lesions where there's been sites of trauma or pressure, and they're different forms. Chronic plaque is by far the commonest sort, the one I've just shown you, 90%. And I'm going to show you examples of acute onset guttate psoriasis, which occurs particularly after a streptococcal sore throat, flexural, and then erythrodermic. It's linked to inflammatory bowel disease. About 1 in 10 people with inflammatory bowel disease have psoriasis. And then it is also strongly associated with obesity. In fact, obesity is a risk factor for developing psoriasis. And it's linked to cardiovascular disease, hyperlipidemia, depression, and also diabetes. So you should be thinking about treating more than just the skin. So here is, you can see these two pictures here on the right are presentation of psoriasis in skin of color. Here it's not so red, it's more of a gray appearance. And sometimes it can have this annular appearance because the plaques, if you had a time-lapse photography, I guess you'd be able to see these are gradually over a period of months are spreading outwards with the lesions clear in the center. And then the symmetry is often very remarkable. This is guttate psoriasis on the top left, and particularly in young adults and children, comes on very rapidly, mainly on the trunk, so-called centripetal distribution, which is often resolves, about 50% of cases resolve spontaneously. This is the psoriatic arthritis, which is usually asymmetrical and affects the distal interphalangeal joints. Flexural psoriasis is not scaling, can be mistaken for an underlying fungal infection. Joint involvement, this is the classic, the classic nail involvement, which is pitting of the nail like a thimble. It can be, psoriasis can be much more widespread. This is erythroderma, where more than 80% of the skin surface area is involved. We'll come to this later on. And this is Koebner phenomenon, where the pressure of the watch strap has actually stimulated occurrence of psoriasis in a person who has psoriasis elsewhere. Treatments, we have a lot of different treatments for psoriasis, particularly using coal tar, topical steroids, or nowadays, particularly vitamin D analogs, often combined with a corticosteroid. We can use narrowband ultraviolet light, ultraviolet B, that's phototherapy. And if the patient has more extensive disease, particularly if they have psoriatic arthritis, they may require systemic therapies. So second-line systemic therapies are methotrexate. That's probably the most commonly used systemic therapy worldwide for psoriasis. But nowadays, we have some very powerful and very effective biologic therapies which target key components of the immune pathways that drive psoriasis, such as anti-tumor necrosis factor, such as adalimumab, and then the new biologics which target interleukin-23. So we've made a lot of progress in our understanding and our management of psoriasis, but it's important, I think, to manage also the morbidities such as the cardiovascular disease. So let's move to this man then. So this is a man in his late 30s. Has a very itchy rash on his face and also on his arms and trunk. And this is atopic eczema. Atopic eczema classically affects the flexures. Remember, psoriasis is the extended surface, and with atopic eczema, is less well demarcated. It doesn't have that clear cutoff between the normal skin and the involved skin that you see with psoriasis. And often in dark skin, you can see this post-inflammatory hyperpigmentation. It's very common. It's particularly increasing in prevalence in the developed world. It's a disease that's different to psoriasis, and it's actually driven by Th2 cytokines such as interleukin-13 and interleukin-4. And it's linked to a deficiency of an important structural protein in the epidermis, which forms the barrier called filaggrin. And it's associated with atopic asthma, the lesions, and also food allergy. The lesions can sometimes develop papules or vesicles, particularly in the flexural sites, often get secondarily infected, and dryness of the skin and itching are often the main complaint that patients have. Importantly, it can become secondarily infected, not just with bacteria, but also with herpes simplex. This is Eczema Herpeticum, which is an important condition to recognize. These little umbilicated lesions is all herpes simplex secondary infection. So the management, emollients are important, with or without antibiotics for secondary infection, with or without antihistamines. In children, consider diet. A dietary cause of eczema is unusual. And think about potent topical corticosteroids. Those are often the main, and people are frightened to use those, but used carefully are actually very effective treatments in the short term for eczema. The nurses will tell you about wet therapy and also phototherapy, which is ultraviolet B treatment. And quite often nowadays, particularly in adults, we use systemic therapies such as oral corticosteroids, cyclosporin, and now we've got some new treatments coming through for this very topic eczema. Dupilumab is a biologic that targets interleukin-13 and interleukin-4 receptor. And also those JAK kinase inhibitors have also now started to be approved for the management of atopic eczema. So there's a lot of progress in management of this disease. Topical corticosteroids are ubiquitous in the treatment of inflammatory skin conditions. You've got a range of potencies here, from the very potent, such as clobetasol propionate, to the very mild, which is hydrocortisone 1%. So this is a young person who presents with this itchy lesion here. This is where you need to think about the history. What could be coming into contact with this site? Well, here, this patient is allergic to the nickel in the stud of her jeans. So this is a contact dermatitis, in this case, an allergic contact dermatitis. And this can take, there's many different contact allergens. This is a person who is allergic to a shampoo that she's been putting in. No, sorry, this is a person who's allergic to a fragrance. She's put this behind her ear. This is where she sprayed the perfume onto the side of her neck, and she's allergic to that. This is an individual on the right here is allergic to a constituent of his shoe, which is probably, and you can see here, the same here. This is a person who's allergic to the rubber in his sandals, which has produced not just eczema, but post-inflammatory hypopigmentation. This is an allergic contact dermatitis. There's also irritant contact dermatitis, which is commoner. People who have their hands in irritant substances, so people who are doing a lot of washing up, people who are in contact with petroleum and other irritant products. It's usually on the hands, usually on the dominant hand as well. Very itchy, particularly in the interdigital spaces. So you see someone with dermatitis. What does the dermatologist do? Well, you're trying to work out the history of what could be causing the problem. You can contact what's called patch testing, putting this little these little patches of chemicals on the back, which we think they might be allergic to, such as nickel or other substances. And then after 4 days, you'll see this response, which is an allergic response to the substance that is producing the rash. Another condition which presents really quite commonly, but often we don't find a cause for it, is this. The patient presents with a sudden onset of very itchy lesions. They're raised and they only last for a few hours. And this is urticaria. Again, I think it's a condition that most of us in this call would have experienced at one time or another. It can be very widespread. It can be limited. It can be very dramatic. This is so-called angioedema affecting the lips and around the eyes. Can affect any age. Equal sex incidence is driven by mast cell degranulation with IgE response. You have the classic itch, flare, erythema, and whealing. These are wheals here on the left. Angioedema is the swelling of soft tissues. Angioedema is not anaphylaxis, but of course it could be a precursor to that if it comes on very quickly, where the airways are affected. Idiopathic, we don't find a cause for it, but you should always consider infection, viral, bacterial, or parasitic. Foods, such as cow's milk, hen's egg, nuts, seeds, antibiotics, stings, blood products, very rarely vaccines. Of course, that's all in the news at the moment. And then contactants such as latex. But there are aggravating factors which may actually make the urticaria worse, such as pressure or infection, or various drugs such as non-steroidal anti-inflammatory drugs and opiates. And then there are a number of dietary so-called pseudo-allergens, such as salicylates, histamine, which is present in some foodstuffs, food additives, particularly food dyes, spices, alcohol may bring on urticaria. And some women, they have a urticaria, but more commonly in a premenstrually, and then stress can affect urticaria and make it more likely to appear. And that's true for a lot of inflammatory skin conditions. I'm not going to go into any detail. You'll have a copy of this slide for urticaria investigation, but it's important to rule out potential causes, everything from foodstuffs to infection, Helicobacter pylori, and stools for ovi, cysts, and parasites, particularly intestinal worms can actually lead to urticaria. But it's important to think of a full workup before you subscribe it, unless you can't. If there's a very obvious reason for the patient getting urticaria, especially if there's a foodstuff that always brings it on, so it's a shellfish, then that would be, there's no need to go into this detail. So this is another case, a man who presents with this extensive erythema. This is erythroderma. More than 80% of the body surface area is affected. There's a number of different conditions that cause erythroderma: eczema, psoriasis, some lymphomas, particularly the skin lymphomas, such as T-cell lymphoma. A number of different drugs cause erythroderma, as you see here, particularly phenytoin, carbamazepine, hereditary disorders, forms of ichthyosis, and rare conditions such as pityriasis, rubor pilaris, and a host of other rarer skin conditions, but the most common ones are psoriasis and eczema. So the management of erythroderma in adults is to try and work out what's caused it, whether it's eczema, psoriasis, a drug, infection, lymphoma, or some other cause. Quite often we don't find a cause though. And then routine bloods for lymphoma, skin for an infection, treatment of the specific conditions. But it's important to know that with the erythroderma, there is you need supportive care. The patients may have high output cardiac failure. They have difficulty maintaining their temperature, so they may actually be hypothermic. So the patient needs to be managed in a heated side room, intensive topical therapy, maybe with potent topical steroids, whilst you work out what is the underlying cause. So this is a serious condition. We sometimes get called down to the emergency room to see a case such as this with extensive blistering. You can see this poor man has a lot of erosions here across the trunk and the limbs of sudden onset. And this is toxic epidermal necrolysis, which is linked to Stevens-Johnson syndrome. It particularly affects the mucous membranes. You can see the eyes are affected. It's a severe mucocutaneous reaction to a drug. You get widespread epidermal epithelial sloughing. So there's necrosis of the epidermis. So that Nikolsky sign, of course, is positive. It's rare, about 1 to 6 cases per million per year. It's for some commoner in women. And most cases, about 85%, there's a culprit drug that's demonstrated. These are the common drugs: allopurinol, carbamazepine, lamotrigine, non-steroidal inflammatory drugs, phenytoin, sulfur-containing drugs. It's life-threatening, needs to be managed in a specialist unit, either intensive care or burns unit, heated environment, fluid replacement, nutrition, prevent or treat infection. Analgesia is important because this is extremely important. Eye care is important as well because you want to prevent corneal scarring. And then there's some debate as to whether, certainly if you see the patient early enough, systemic corticosteroids or cyclosporin are important. But if the patient has underlying comorbidities or is elderly, the risk of death is high. So this is a life-threatening condition. So we're just going to close now with some sort of important warning signs or red flags. So in some people, skin conditions can be the sign of underlying disease, including many designated by the WHO as neglected tropical diseases. So always have a high element of suspicion. So if you see solitary large dry scaling patches, test the sensation of the area by asking the patients to close their eyes and then gently stroke the patches to see if they've got loss of sensation. This is particularly important where leprosy, which in parts of Myanmar is true, is endemic. The tuberculoid leprosy presenting as a pale patch, there's loss of sensation in this area. So pale patches with loss of sensation, think of leprosy. Leprosy tends to get overlooked. Still common, still there. What about people who present with pale and dark patches on the skin? Well, leprosy we've just talked about. I'm going to show you some pictures of vitiligo and pityriasis versicolor. Psoriasis can occur as dark patches on the skin, and as can lichen planus. And then the post-inflammatory hypo or hyperpigmentation. I've shown you examples of both of those, are important to take into account. The vitiligo, autoimmune condition, antibodies directed to the melanocytes. It's an inflammatory reaction, well demarcated, particularly on the extensor surfaces and around the mouth and the eyes. It's asymptomatic, it's a patch. Pityriasis versicolor, very common, this little raindrop-like appearance of loss of pigment, particularly on the upper trunk, fine scale. Pityriasis means bran-like, so it's a very fine scale, and it's caused by a pityrosporin yeast called Malassezia. And then children, eczema can sometimes present these pale patches of hyperpigmentation on the face called pityriasis alba. And then finally, HIV. It's need to be aware that HIV has a number of skin conditions which are linked to it. So patients with underlying HIV infection can present with a number of skin conditions. Any of the following indicates the need for further testing. So actually sudden, I haven't put it on here, but sudden, yeah. So numerous small papules on the face or body with a small central area of softening. Could be, if it's multiple in an adult on the face or body, think of molluscum contagiosum, maybe underlying immunosuppression. Candida, bruise-like patches on the skin, the roof of the mouth indicate potential presence of Kaposi's sarcoma. Now, when I started dermatology, we saw the very first patients with HIV in the UK back in the 1980s. And many of those presented with severe seborrheic dermatitis, and in some cases, sudden onset of psoriasis. And there's an unusual folliculitis, eosinophilic folliculitis, very itchy, particularly on the trunk, which is associated with HIV infection. This is molluscum contagiosum, these umbilicated, translucent papules, very widespread in patients with HIV infection. And this person has Kaposi's sarcoma on the palate and on the tongue. So I've talked about a lot of things here. We've gone through the basics, we've gone through the description, how to take a history, a little discussion about the anatomy, and I've shown you a few diseases, but remember in dermatology, there's over 2,500 different diagnoses, different diseases. So I've just given you a little insight into the beauty of dermatology. This is the book that we've just published recently, which I think is a good handbook for recognizing and diagnosing skin disease. And if you want to contact me, this is my email address. Very happy to hear from you. And of course, take any questions if you have any today. So that's a whistle-stop tour, a lot of things to think about. And hopefully you've learned something there, but happy to take questions.
Thank you so much, Professor Griffiths. You would have seen that there's been a flurry of questions in the chat box, and I have to say I'm really very excited because, you know, clearly your teaching has been very effective and it has invoked a lot of curiosity as well. So what I've been trying to do was, you know, there are some questions which were fairly straightforward to answer over the chat. So I have actually been replying to various ones with.
Yes, I can see that. Thank you for doing that. That's,
but what I'll do is, if I may, I'll moderate the sort of questions that'll be useful for you to, if you don't mind kindly answering, actually. Mm-hmm. So I'm going back from the beginning. So the first question from Serena is that why do you see golden crust in impetigo?
Well, the golden crust is really the dried serous exudate So it's really dried pus, if you like. Yep.
And she also asked about why do you see a black color skin in cellulitis?
Well, in cellulitis, that picture, that's when you've got more extensive disease. There may be some vascular occlusion there, or there may have been some bleeding. So it's a vascular occlusive.
Great, thank you. And somebody else called Hal, I'm not sure, and he said, how long do you provide the treatment in cellulitis?
Well, the treatment the treatment is usually a course of antibiotic. If the lesions, if the cellulitis is resolving or resolved, then you can stop. But some patients, when they have a predisposing, maybe a lymphedema, may require chronic low-dose antibiotics, such as a form of penicillin. But usually it's just as you'd manage any infection, a course of antibiotic until the condition is cleared.
Great. And Serena asked, why do you need to bathe after malathion?
Say that again.
Why do you need to bathe after applying malathion, however you pronounce it?
Well, bathing, no, it has to be left on for eight hours at least, and then to wash it off, because it because it can be then transferred maybe to the eyes or to elsewhere. So you don't want to leave it on for longer than necessary. It can be irritant. It's irritant if it's left on for a long period of time.
Yeah. So you need to make sure that you wash it away so that you don't have the irritant dermatitis afterwards.
Yeah.
So Dee asked, how does scabies cause chronic renal failure?
Because you get a glomerulonephritis.
And another question was about
the glomerulonephritis is not due to the scabies directly, it's due to the secondary infection, often with strep.
Thank you. So Hal said, how long do you give corticosteroids in alopecia areata?
Well, that's a very good question. I think I'm a little bit unsure about corticosteroids. They can be used. It's worth trying because the patients it's a very distressing condition because it can occur very suddenly, and patients are often very, very distressed by this. There's no real good markers for whether it's going to, for how long it's going to take before it resolves, if it is going to resolve spontaneously. So we use very potent topical steroid for no more than about 2 or 3 weeks. It can be used intralesionally if there are just 1 or 2 discrete patches of alopecia. But systemic corticosteroids, I'd be less keen to do that because you can run into long-term problems of systemic corticosteroids, and those of which I'm sure you're quite aware of the systemic consequences of being on long-term steroids. But I'm quite excited. I'm excited about these new JAK kinase inhibitors, which are now being approved for the management of alopecia areata. So they would be safer to use, certainly than steroids, over a long period of time. And this is a direct result of some very good research work that's been done on alopecia areata, genome-wide association study, where it was identified that targeting JAK kinase would actually be, JNS kinases would be an important and potential druggable target, which it is. So that's translational research at its best.
No, definitely. Thank you for that. And just to contextualize everything that Professor Griffiths has spoken about, of course, you know, the current circumstances that a lot of people are in, it's all very difficult, but I think it's really important to learn about what is going on at the cutting edge, you know, scientific development around the world. Bearing in mind that, of course, depending on the local context, things may not be available, but at the same time, in Myanmar, for instance, you know, there are a lot of medications and drugs that can be ordered from Singapore and various other countries. So I think it is really vital to know what are the latest research translational research developments and so on. So
yeah,
thank
that's
you.
a very
You for
good point that you make, Dr. Lewin, because particularly for the biologic therapies that I mentioned for psoriasis, I could give a whole lecture on this, but those are very expensive. But now, though, we have what are called biosimilars, which are much cheaper versions of the biologic therapies, such as the anti-TNFs. And I am hopeful that as these costs are coming down, and they're about a tenth of the price they were even about 4 or 5 years ago, they may be available for people to use in Myanmar. And the data that we have, as long as the correct screening is done, these are remarkably safe treatments.
Yeah, thank you. And of course, with Alopecia Areata, in some cases, you see spontaneous regrowth of hair. And Amy wanted to know, when might you observe this in some patients?
Well, as I've said, it's difficult to predict, but usually we'll tell the patients that it should come back within 6 months. But there are no good markers as to how long it's going to take. And some people, it may relapse again as well. So
yeah.
Just because it's really, but sometimes it relapses at times of stress, interestingly.
Absolutely. No, and great question. Of course, it goes to show that there's still a lot of research that needs to be done in trying to predict the, not just alopecia areata, but the disease prognosis and also outcomes as well in a lot of patients. So moving on to HIV, Serena would like to know, why do you get scabies in HIV?
Well, scabies tends to be more widespread in people who are immunosuppressed. I think it's just because it's not such a concerted immune response to the scabies mite, so it can actually spread quite rapidly in the skin, in sort of being relatively undetected.
Absolutely. So in a way, anyone can get scabies. It's just that the immunosuppressed state actually doesn't fight it back sufficiently. So no, that's great. And then she wanted to know about pemphigus. So which body sites do you normally see pemphigus typically?
Well, pemphigus typically, yeah. So yeah, no, that's another very good question. So I made the distinction between pemphigus and pemphigoid. Pemphigoid tends to be more common in the flexural sites, and my pemphigus, there's different. I didn't want to go into make it too complex, but Pemphigus vulgaris, there's several different forms, but Pemphigus vulgaris, particularly common on the trunk, that lady I showed you at the back, and also on the chest as well, and also the face, the cheeks. But the mucous membranes are nearly always involved with pemphigus.
Yeah, absolutely. And I guess foliaceous will be a slightly different picture. But yeah. So you tend not to see mucous membrane involvement in foliaceous, which is another subtype of pemphigus.
Absolutely right. I wasn't going to go into that detail, but yeah, there's this more unusual form of pemphigus called Pemphigus Foliatious, where the desmosomal component that is targeted by the antibodies is much higher up in the epidermis, so blisters are even rarer than you'd see in Pemphigus vulgaris, and as Dr. Lewin says, it tends to be much more on the face.
Yeah,
but also on the chest and upper back as well.
Yeah, absolutely. I actually brought it up because the patients whom we saw in Mandalay and also in Yangon were more reminiscent of foliaceous in a lot of them as well. So that could be relevant as well, even though it is of course super rare. Moving on to the next.
Just before we move from that, yes, you're absolutely right. I mean, we did see these cases, and some of them were from the Irrawaddy River area, and there's a condition in South America, in Brazil, called Fogo Selvagem, or wildfire, which is a form of Pemphigus foliaceous, where the vector is a black fly, a biting insect, and it seems that there may be a reaction to maybe a salivary component of the black fly, and we just wonder if that might be the case in Myanmar as well. So there's even more research to be done. They're going to finish up with a huge research program here. Sorry to interrupt. Yeah.
No problem, absolutely. And in fact, if anyone is interested at the end of the talk, you're very welcome to contact us, both Professor Griffiths and myself. And I'm happy to provide my email address as well in the chat box about anything to do with skin. So Amy asked about Nikolsky sign, which I have put in the chat box. The next question by Hal was about how long do you give corticosteroid and doxycycline in pemphigoid, bullous pemphigoid?
Again, it's until the lesion, until it's cleared up. So the way that it's, this is, you could monitor the patient by looking at the antibody titers, or usually it's done on, are they developing any new blisters or not? And once they stop developing new blisters, then you can then start to taper off the corticosteroid, the topical corticosteroid, and or the doxycycline. But doxycycline can be continued beyond the clearance of the condition, maybe for a month, just to be on the safe side. And of course, it's safer to do that than to have someone on longer-term systemic steroid, particularly in the elderly population who are more susceptible to pemphigoid.
Yeah, and of course, it's an art that you develop with experience and also with the latest evidence, changing practice in the future as well. So it's based on evidence guidelines plus your own personal experience, I'm sure. Amy asked about ice pick scars, so I have put in a link about ice pick scars as an example. And Serena asked about what causes acne.
What causes acne? That's a great question. It is extremely common. It seems to be more common in the developed world. It may be, there's a lot of theories about acne. I think the first thing to say is that it's not associated with junk food necessarily. So people say, is it associated with eating too much pizza or too much chocolate? Maybe not, but of course there are other reasons why you shouldn't have too much pizza or chocolate. But there is one school of thought, though it's not proven, that maybe it may be a change in microbiome, and it may be which is being dictated by processed foods, which may in part link to why it's getting commoner in the higher income countries. So processed food may actually play a role here, but it is not well understood, even though it is so common. I think the interesting thing is that it's an inflammatory skin disease, the same as maybe eczema and psoriasis. And it wouldn't surprise me that we start to think about managing it as an inflammatory disease rather than just managing that blockage of the pilosebaceous follicle, as we discussed with getting rid of the blackheads using topical benzoyl peroxide or retinoid, or the systemic retinoids in some patients. And the reason for using the antibiotics is not because of the Propionibacterium acnes, which has an overgrowth, but because the antibiotics we use, the tetracyclines, have an anti-inflammatory effect.
Thank you. No, it's really absolutely fascinating. Would you care to expand on the concept of microbiome? Because I'm conscious that they may be familiar with this concept.
No, for sure. So microbiome is, well, there are more, our bodies contain more foreign cells than our own cells, and these are the bacteria that inhabit our skin surface and also our GI tract. And there is now, and that is our microbiome. So it can be a skin microbiome or gut microbiome. And we all have our own individual microbiome, but it's in homeostasis. And it's now been shown that if the microbiome, particularly in the gut, is changed, that may make people more susceptible to various inflammatory conditions, such as psoriasis, such as atopic eczema. And there's now work to show that actually the microbiome in the gut may be linked to depression as well. Of course, depression quite often is a inflammatory condition. So there's inflammation in the brain, often with with depression. So there's considerable work now looking at how one can, what's the link between microbiome and skin disease, not necessarily the skin microbiome, but the gut microbiome as well, and how changes in that may alter the immune response in the skin and tip it over into a skin disease.
Absolutely.
So that's a very exciting area, actually.
Yeah, thank you. So a bit more about acne, and then I am conscious of the time. So what I might do, Professor Griffiths, do you, if you don't mind, we could extend it to another 10 minutes or so.
Sure, very happy. I mean, the questions are excellent questions.
Yeah, absolutely. And then, you know, I appreciate that some people had to go, but we still have 31 out of 38 originally left, so that's really good. Next question is still about acne. It's much more about the initial management of acne, you know, first line, second line, and so on. If you could kindly expand on that, please.
Yeah, I think the first thing is, as with the management of any patient with any skin disease, is to talk to the patient about what it is, you know, what we know about it, what it is and what it isn't. So there's a bit of education is important. I think it's also, as I mentioned at I think the end of the little piece about acne, is important to understand the psychosocial aspects of acne. Some people are relatively unconcerned and they've been brought along quite often by a friend or their mother, or they are seemingly disproportionately concerned about the acne, and it can actually in some cases lead to suicide. So the psychosocial aspects need to be taken very, very seriously. The initial treatment is just ordinary normal skin care. So washing, but not you know, with not with any harsh abrasive soap, but just gentle washing. The use of the most common treatment that we use first up is benzoyl peroxide, which can remove those comedones and maybe free up the blockage of the pilosebaceous ducts. If the patient has, let's say if they've got mainly comedonal and just a few papules, small papules and pustules, but if it is more inflammatory, so there's more inflamed papules and pustules, and particularly if it's onto the trunk as well, then in addition to using maybe chlorhexidine or benzoyl peroxide, then one should consider a systemic therapy, and usually the first one we use is a tetracycline antibiotic, or occasionally erythromycin. So one can go from a topical erythromycin or topical topical clindamycin to a systemic antibiotic, but and those need to be used for at least a couple of months to see any improvements. So you can't sort of say something's not working if it's not much, that you don't see much after the first 2 to 4 weeks. You need to stick with the program, so to speak.
Thank you. So Amy asked about what does flexural means, then I'll put that in the chat with the links as well. Yeah. And the next question is about why do you see red and gray discoloration in psoriasis? So presumably he meant the red skin and the grayish silvery scales. Yeah, so yeah, well, I'm very aware, and the sort of textbooks that I'm involved with are certainly have been guilty with this over the years, that we've changing it, you know, quite rapidly now, is that most of the textbooks are written with white type 1 to 3 skin in mind, rather than type 4 to 5 skin, which is a much darker skin. And of course, the background skin color dictates quite often the way that the skin rash might appear. So the red of psoriasis, which is due to the increased blood flow, that's the reason that lesions are red. It's just purely a consequence of increased blood flow. Can look in dark skin looks gray. So the red and pink that we see in Caucasian skin is not as obvious. It tends to look gray. And the scales themselves on that background also take not so silvery and white as we see on that red background.
The scales are very, very classically have a silvery tinge to them. But that's the difference between the two. We've come up now with clinical diagnostic criteria for diagnosing psoriasis for some of our studies which we're doing around the world on the prevalence of psoriasis. And we don't necessarily have to rely on dermatologists to do that. It's people such as medical students who don't have a lot of dermatology experience but can definitively make the diagnosis using one essential criterion and at least four non-essential criterion.
Thank you for that. So Amy asked about what is coal tar and what is dathanol. So I have put in the links where you could look up a bit more about that. But interestingly, Hal asked that why do you give vitamin D in psoriasis?
Well, the reason, it's like, that's another very good question, actually. There was work done back in the mid-1980s in Japan, where patients had been given vitamin D for renal disease, and their psoriasis had improved. Their psoriasis had improved. And so then there was a full-scale development of not using systemic vitamin D, because of course that can have a significant number of side effects, such as calcinosis and renal impairment, but topical vitamin D derivatives such as calcipotriol. Now, it is originally thought it might be because patients with psoriasis were vitamin D deficient. That doesn't seem to be the case. It's probably because vitamin D has an anti-inflammatory and anti-inflammatory effect combined with a effect on the epidermal cell proliferation. So, and I didn't have time to go into this, but psoriasis has the epidermis in psoriasis is turning over very rapidly, about 7 times the speed that we see in normal skin, which is why it's thick and why it's scaling. And vitamin D may have an anti-proliferative effect as well. But that's a very good question, because I think that we don't truly understand how it works. We know it works, but it's like a lot of things in medicine. We don't probably know, it's not always a reductionist approach like we have with the biologics. We know we found out the immunology and then designed drugs to target that. Sometimes things come out of pure serendipity, but we should always embrace those opportunities.
Absolutely, really exciting and fascinating, isn't it? That's why we do what we do, I guess. So next question is about what is UVB, PUVA, and TH2, which I have put in the answers in the chat box. But would you kindly expand what is filaggrin a little bit in the context of eczema, etc.?
Well, filaggrin is an important protein. It was, again, this was not, so we know that the inability to produce filaggrin, which is important in producing the skin barrier, the stratum corneum. This observation came out of it has been observed for many years that people with eczema were more likely to have a condition called ichthyosis. It means it's like a scaly skin, particularly on the sides of the neck, and something called Ichthyosis Vulgaris. And they'd known for many years that Ichthyosis Vulgaris is linked to this deficiency or mutations in the production of filaggrin. And then Erwin McLean, who's a professor in Scotland, did some very nice work to show that actually patients with atopic eczema, not all of them, but quite a large number of them, have this mutation in filaggrin. So they're not able to form the skin barrier as well as people who don't have the mutation. So that then changed the direction. People are now working on potential ways of restoring the filaggrin to normal, but most new treatments are still targeted at the inflammation, which is probably secondary to that impairment of the skin barrier.
It just, I'm just thinking about how curious all the students are. And of course, one may think that in light of the challenging and really unimaginable circumstances, but that curiosity is really key. And thank you for firing us with questions. So I'll swiftly move on to other ones if we've got 5 more minutes.
Yes, of course.
So why does food allergy cause atopic eczema?
Well, I think it's very unusual that food allergy is the underlying reason for atopic eczema. But some people with atopic eczema have a more sensitized immune system to various proteins, of which, of course, food contains proteins such as peanuts is the common one, or dairy. So many, and you'll probably hear this from when Professor Malario speaks to you next week, is that when I see children with atopic eczema, often the question that the parents want to know is the child allergic to some sort of food, and should they go onto a special diet? Unless there's very strong evidence, I would say that there's no need to do that. Because I think it is highly unusual. Quite often, though, children have an allergy or response, not so much an allergy, but certainly the atopic eczema seems to be stimulated by the house dust mite.
Absolutely.
Yeah,
Now, next one may be a little bit trickier question to answer. Which topical steroid is best with less side effects?
Well, that is easy to answer, actually, because you have to use an appropriate topical steroid for the situation. I think the biggest concern that people have is that that often, certainly in the UK, in general practice, is that there is a steroid phobia. So patients get treated with a very low potency steroid, topical steroid, such as hydrocortisone. And a hydrocortisone, 1% sounds as though it's a serious heavy duty steroid, but of course it's not. It's very mild, it's very safe. But the problem is it doesn't work too well. So if you really want to get on top of inflammatory condition, it's best to start with a more potent steroid and then taper down, with the caveat that don't use topical steroids of any high potency for more than 2 weeks on the face, where the skin is much more sensitive, and in the flexural areas, such as under the arms, under the breasts, and the groins, where the occlusive effect of those sites means that there's more steroid absorbed, because then one can run into problems with secondary infection and stretch marks or striae, which is thinning of the skin. But I think the mistake that most people make is that they undertreat rather than overtreat, because nowadays we're very aware of the risks. And of course, sometime when they were first started to be used, the systemic absorption of topical steroids was not well appreciated. So there were patients who became Cushingoid because they were using topical steroids for long periods of time. And in some cases, they actually had osteoporosis as well, with femoral fractures. But that is very rare nowadays, very rare.
Thank you for that. So if now there are several questions still remaining, but so what, I mean, how are you with the time? Should we say another couple of minutes and then we?
Yeah, I'm absolutely fine, but I'm conscious others have things to do. But yeah, I think I agree with you. It's fabulous that people are so excited about this. The questions are just really very good, very practical questions, and we could have a whole. I could get myself into trouble. We could have a whole series of talks on skin disease. But
so what I might do, actually, I will cross-check with Mai, who is who's on the FP2 NUG host. If I am happy to stay on if it's okay for everybody. And then to finish up all the questions, and then any further questions to be emailed to us. I think that might be best, actually.
Absolutely fine.
I can see that a couple more people have left.
No, absolutely fine with that. So let's go for 2 or 3 more minutes.
2 or 3 more minutes. All right.
Okay.
So about allergic contact dermatitis, are there any particular types of fragrance that causes it?
There's a whole list of fragrances. I think bergamot containing ones are probably the commonest, but what I've learned dealing with the contact dermatitis experts is that you can be allergic to pretty much everything or anything, even some components of topical steroids. So it's a complex area, and most of these sensitizers have very complex chemical names as well, which I can remember for no more than about 15 seconds. But I can send you that book I mentioned at the very end. We have quite extensive lists of the commoner sensitizers, but bergamot is particularly common. The other one that we see increasingly nowadays is acrylics hardeners in nail varnish.
Absolutely, and of course, the sort of sensitizers that we see in EMR will be different from the UK, I would imagine, with a lot of occupational allergic contact dermatitis being quite commonly found. So I think it will definitely be useful for you to have a list of it at some point.
Yeah, we can certainly send that.
Thank you for that.
There are yes, and often it depends on occupation. So the contact dermatitis experts I've worked with will quite often do a factory visit, to where the person is working, to ascertain what's in the environment. And one we did recently was where the person was allergic. They had an eczema on their face, and they had a contact. They worked in a timber yard, and it was in an enclosed space actually, where they were doing the sawing of the timber, and they were allergic to components of the wood dust.
Yeah, no, that's great. Very, very briefly, Amy would like to know the difference between flare versus a wheal.
Well, a wheal is really when it's palpable, actually. I think flare is the redness that you see, and the wheal is really when you've got the when it's raised. I think that's probably the easiest way to put it. So urticaria, as you know, is raised. You can, I'm sure if you've had urticaria, it's a nettle rash. So it's itchy, stinging, and then it becomes red, and then it becomes then it's raised and palpable.
Yeah.
And the key thing is that they don't last long. The individual lesions.
Absolutely. So going along with urticaria, why does menstruation cause urticaria in some females?
It doesn't cause it, but it makes them, if they're going to get relapsed, they often they can get urticaria at other times, but it seems to be particularly pronounced at the time of pre-menstruation, and that's due to probably progesterone release. And that's true with some other skin diseases as well. Atopic eczema may sometimes flare. Acne, as I'm sure that many of the female students on the call will know, can often be worse pre-menstrually as well, probably for the same reasons. But there's a strong link, and we don't really understand it, as the inflammatory effects of particularly female hormones.
Fascinating, isn't it? So hormonal role in certain skin diseases, we don't quite understand.
It is really fascinating, and I saw an example of that is that, not that I'm recommending this as a treatment, but psoriasis will quite often resolve completely during pregnancy. It doesn't say it goes away completely forever, and it often comes back, but it will often go completely into remission during pregnancy.
Would you very briefly kindly clarify the difference between erythroderma and eczema?
Well, erythroderma is when you have more than 80% of the body surface area affected by a red inflamed, when the skin is red and inflamed, more than 80%. And that is, that can be caused by eczema, it can be caused by psoriasis. So it has very extensive eczema, very extensive psoriasis, very extensive drug eruption can be a cause of erythroderma. So erythroderma is not it's a sign, if you like, but it's not a diagnosis in its own right.
The eczema in Myanmar would be Yana. What is stress? What is CTCL? What is WSPLP? I've put those in the chat for the answers. And the next question's about, why do you transfer the patient to heated environment in TEN?
Because the skin is highly inflamed, with TEN. They are at risk of hypothermia because, as you mentioned right at the start of the talk, one of the main functions of skin is thermoregulatory because of the blood flow. And That's why when you're feeling cold, your skin becomes white, because the blood flow is trying to preserve the blood is diverted to the more important, though I think the skin is very important, vital organs.
And why
when you're hot, then your skin is red, because you get all that blood flow in the skin to try and lose heat. But people with TEN, pemphigus, erythroderma, they lose that thermoregulatory ability.
Absolutely. And in addition to redness, of course, you don't have the epidermis becomes necrotic, and then they just, of course, they are no longer present. So skin has failed.
Yeah, exactly.
Why is it more common in females than males? Why is TN more common?
We don't know. We don't know that. I'm afraid it may actually come down to what we were talking about just now, hormonal influences.
Yeah. And Harley was interested in the first few slides of our visit to Myanmar, you know, some of the diagnoses that you described, you showed. So if you could kindly explain what these were.
Well, we saw, so on the ward round in Mandalay and in Yangon, we saw cases of very severe psoriasis, and we saw quite a few cases. I think in Mandalay particularly, most patients on the ward were women with Pemphigus Vulgaris and Pemphigus Foliatious. So that was in there. In the orphanages, the commonest conditions that Dr. Lewin and I saw were scabies, Tinea Capitis, which is fungal infection. I didn't have time to go into this because it's mainly a childhood condition. Tinea Capitis, which is fungal infection of the hairs of the scalp. That was extremely common. And also eczema. And then we saw some other conditions such as congenital hemangiomas. And then in the clinic we did down in Kalthong, right down in the very south of Myanmar, we saw a fascinating range of cases. We saw cutaneous lupus erythematosus with the classic so-called Tintac signs in the ears. We saw Pemphigus Foliatious, scabies, acne, a lot of different conditions. So I think that when people, so I think that it was, that's the great thing about dermatology, is that there's such a huge range of conditions that you might see, everything from infection. We didn't talk about cancer today, I didn't have time, through to cancer and inflammatory skin disease. But the great thing is we're now developing a better understanding of these conditions and have some very good treatments nowadays.
Great. Now moving on to HIV, Han wanted to know about HIV-related conditions. Can they be seen in other immunosuppressive patients without HIV?
Well, that's again a good question. So they can. So extensive molluscum contagiosum, extensive Tinea Corporis, particularly see in immunosuppressed individuals. Some of the conditions are seem to be very peculiar to HIV, such as the eosinophilic folliculitis. That's rarely seen beyond that. I think the important thing about HIV, and what I learned right back in the day when I was first starting out in my training, was that patients with HIV can get very dramatic presentations of what are common infections, such as extensive molluscum contagiosum, extensive viral warts, or they can develop, or they can present, certainly in the UK, with infections that we do not normally see, such as histoplasmosis. Yeah, there's a whole book's written on this, and it's important though that if you see extensive infection, herpes simplex is another one, which is can be very extensive, as can herpes zoster as well in these people, and they are immunocompromised.
Absolutely. Another great question now coming up from Han as well. What is the relationship between psoriasis and obesity, hyperlipidemia, and diabetes?
Well, this is a great question. I've spent quite a few years looking at this. So psoriasis is known to have psoriasis is associated with increased risk factors for hypercholesterolemia. cardiovascular disease. In fact, there's a higher mortality from cardiovascular disease in people with extensive psoriasis than in the normal population. As I mentioned, obesity and weight gain are a risk for developing psoriasis in genetically predisposed individuals. And the reasoning behind the rationale for why that might be the case is that the fat is not an inert compartment. It actually contains and produces a lot of inflammatory cytokines, such as TNF-alpha, which then stimulate the skin to then become inflamed in the background of a genetic predisposition. So we do know that people who have psoriasis, if they lose weight, and there are some studies using bariatric surgery, that their psoriasis can often come under much better control and sometimes resolve. So part of our management of psoriasis now is not just getting people on the right drug, it's actually on the right lifestyle as well, of which losing weight, stopping smoking, stopping alcohol consumption, all help the management.
No, that's great, thank you. And we've got about 4 more questions and then we're done, I believe. So next one is about Pemphigus eczema. Is it a chronic condition? Is there any cure for it, and what can be applied?
Yeah, Pemphigus eczema, I didn't have time to discuss this, but I'm glad they picked it up on one of the slides. So this is the vesicles, small blisters, particularly on the palms and soles. And eczema can be quite difficult to treat, often associated with stress, actually. So again, it's when you manage the patient with Pemphigus eczema, it's important to take a good history and to understand, the background to the individual patient, because there may be stress at work, there may be stress at home, there may be other stressful life events that are driving the chronicity of that condition. But other than that, though, it's either topical steroids or maybe systemic steroids may be helpful. Some people use local phototherapy to those sites.
I think you would have realized how much we rely on steroids still, despite being in the 21st century and all the latest scientific developments, we still do rely heavily on topical steroids in reality.
Yeah.
So next one is about Alopecia Areata, back to it, and how long does it take to regrow hair? I guess how long is a piece of string?
Well, the hair will regrow. It usually takes about 6. Well, from the time it starts to regrow, it's going to regrow very quickly. Quite often, though, it will grow back grey or white, because initially, at least, and that's probably because the melanocytes have been damaged initially by the inflammatory infiltrate. But remember, though, alopecia areata is not a scarring alopecia. So there are certain alopecias, hair loss, where one gets permanent scarring, as one might see in lupus erythematosus or sarcoid when it affects the scalp. But that's a whole separate lecture on that. But often it'll come back white or grey.
Which actually,
and so that's the and it's often the dark hairs which are more, or the pigmented hairs which are targeted by the immune process, which probably gives rise to those stories of people going white or grey overnight. They may have had a stressful event which has triggered alopecia areata, and the dark hairs have been preferentially targeted. So they already had some grey or white hairs, and they just left with those grey or white hairs.
Absolutely, and you have touched on the next question about scarring alopecia. So the question's about, is discoid alopecia the same? Oh, it's not discoid as in discoid lupus, but discoid alopecia same as alopecia areata. So I guess there's a differential.
Well, I mean, discoid, you could use that term to describe the coin-sized, coin-shaped patches of hair loss. So you could use discoid for that. But then there's a form of cutaneous lupus erythematosus called discoid lupus, particularly common in people of African heritage, which is severely scarring. And once there's scarring occurred in the scalp, there's going to be no hair growth at those sites. And that's why treating conditions such as that aggressively and early will prevent further scarring. But alopecia areata doesn't scar though. That's the crucial difference.
Yeah, absolutely. So the final question on alopecia areata is about tapering the corticosteroids. So do you need to wean them off? And it's
yeah, I mean, I'm not a great fan of using corticosteroids, but if you know it's going to be an acute episode, then I would wean off over the period of, wouldn't have them on topical corticosteroid, on systemic steroid or topical steroid for more than a couple of months.
No, that's great. Well, I think that, thank you so much for staying 45 minutes extra behind to you, Professor Griffiths, and also thank you to everybody. I mean, we started off with 30, and then it went up to about 39 at some point, and now we're still 24. So that's actually not bad at all in terms of trying to sustain people's interest. So, and thank you to the NUG for inviting us. Thank you, Mama San, you're online, for inviting us to give this talk today. And
thank you, Masan. Thank you, Prof. It was really a very interesting and informative, comprehensive teaching. And thank you, Masu. You did a very great effort to explain everything. So it was really brilliant.
Absolute pleasure to do it, actually. And thank you for these fantastic questions.
Thank you very much.
Really, very good.
Yeah.
And
thank you also.
I have put in my email address if there's any further, questions or interest in getting involved with skin research or our BSI projects, do let us know.
Yeah,
take care.
absolutely.
So we'll see you next Sunday on pediatrics, common and emergency skin diseases in pediatrics. Okay.
Thank you, Dr. Lewin. Okay.
Yeah, I'm sure it will be very interesting. Yeah.
Bye.
Thank you. Thank you all for your active participation, and have a nice rest of the day.
Thanks so much.
Good luck to you all.
Bye. Bye-bye.
Bye-bye.
Bye.